Hi, my name is Kristyn Heins, and today we're going to be looking at Texas Behavioral Health Integration Advisory Committee for Best Practice in Holistic Treatment. So the holistic approach that we're working from looks at the idea that physical and mental health are not independent of each other. It's important to consider these things when you're working on an integrated team, as you're going to be working with physical health and mental health providers and trying to get the best results you can for your patient. Integrated care teams usually consist of medical doctors, MDs, DOs, clinical pharmacists, also known as PharmDs, LPCs, psychologists, social work, nurses, nurse case managers. There's a whole variety of different disciplines who are involved in this type of team. The different ways that people are generally integrating these different disciplines are through team huddles, so each morning meeting together and looking over the usually the medical doctor's caseload and figuring out if there's a need for any other one of these disciplines to be involved in treatment. Alerting your providers to shared patients, so again, making sure that you have an idea of who's coming into the clinic and what patients are being seen that day, so you can work with the other disciplines who are seeing that patient and maybe have a conversation about what that patient might be needing. And also co-located workspaces is really important. Being able to have quick access to your coworkers and be able to have this conversation with them in an easy way, so eliminating any sort of barriers. Being in the same building is very helpful. Being in the exact same office or workspace is really helpful. Oftentimes we see a shared workspace between social work, mental health counselors, medical doctors, nurses, everybody in the same pod, so to speak, and then various exam rooms around that area, so that way the patient is located in one place and the providers are taking turns going to that patient. So eliminating barriers in engaging patients is really the key in integrated healthcare. So the first thing that we can do to eliminate a barrier is to have a shared medical record. Using the same EMR or electronic medical record or obtaining consent to speak with other providers is so important when working with shared patients. Patients are often maybe a little confused about their medical care, and maybe they're trying to report the information that they know, but it's not all encompassing, or they're missing something, or maybe they've miscommunicated something. So being able to go in and look at that medical record is really important, so you have a good idea of what their other providers are working on. If that's not possible to be able to have the shared medical record, obtaining consent to speak with other providers is really important as well. So if you're seeing somebody in your clinic but they're seeing a primary care provider in another location, being able to have that communication with the consent of the patient is really important. Other ways that people do this are shared portals, which is kind of a new concept. So usually you see this with community-based outpatient clinics, so just primary care physicians, and then hospitals will have this shared portal, so that way when you go for a post-hospital follow-up to see your primary care, they're able to access your hospital records without having to wait up to a couple of weeks really to get that the discharge summary. Care transitions are also really important with eliminating barriers and engaging patients, so monitoring when people are going from inpatient to outpatient and outpatient to inpatient. Usually you'll see social work or RN case management used to track these hospitalizations and discharges. These people are also usually responsible for obtaining the hospital records when somebody discharges, so that way we can have them in the primary care location. So another key piece to eliminating the barrier from a provider standpoint is to understand how medical conditions can impact mental health or vice versa. So providing patient education as well, so that patient has a good understanding of how their different conditions are affecting each other. If there's non-compliance with diabetes, is it because there's a lack of resources, or is it because they don't have the motivation, they're depressed about their current condition, they don't have the desire or drive to take care of themselves? So really having a clear understanding of how these different things affect each other is really important for engaging the patient to help them take care of themselves, as well as eliminating the barriers to treatment from provider to provider, but also provider to patient. Collaborating between the disciplines is kind of a new thing, especially for counselors. Historically, these positions were filled by psychologists or social workers. So counselors are new to this field, and they're really carving out this new role for integrated care, which is a wonderful opportunity, but can be kind of there can be some growing pains there because people maybe don't understand what the licensure is. So the best thing to do here is for the collaborative approach is to build the strong relationships on the interdisciplinary teams. Having an understanding of what each person's role is on that team and how they might be able to help you when you need something for your patient, a shared patient. And really just having a good foundation of communication and understanding and good support is so important when working on these integrated teams. So as far as behavioral health integration goes, the original approach to this was called SBIRT, or SBIRT, and it stands for Screening, Brief Intervention, and Referral to Treatment. Usually we see a screening in the use of like a universal screening tool. So maybe once a year when somebody comes in for their primary care appointment, the nurse who checks them in or their primary care physician will offer them this universal screen where they usually fill out a couple questions related to maybe the PHQ-9, maybe the GAD-7, might look at substance use. Some screening tools might assess for suicidality, or mood disorders too is something that's generally screened for in these settings. This can be either a series of multiple different small screenings, like 2 questions from the PHQ-9, 2 questions from the PCL looking at post-traumatic stress, or 2 from GAD-7, or it can be a 1-page sheet where it has multiple questions on it and can be scored by the mental health clinician on the integrated team. Follow-up screens, full screens, can be given if one of those comes up positive. So if you have a couple questions that are scored for the PHQ-9 and they come up with positive scores, giving the full assessment might be helpful at that point, or the GAD-7 looking at anxiety. And from that point, we're looking at a brief intervention for the primary care mental health piece. So we want to get in and engage the patient in a caring conversation about mental health and substance abuse. You might only have 10-15 minutes to meet with this person, and so just giving them as much information as possible without overwhelming them is going to be really important. You might want to give them an explanation of how mental health or substance abuse is affecting their physical health issues. You might want to assess for any sort of history of mental health and how that has impacted them, and really helping them gain an understanding of this is something that we can work with if you're interested in it. The referral to treatment piece is either making the most appropriate level, or referring to the most appropriate level of care. So if somebody comes in and they have no history of mental health treatment, this is totally new to them, they've never felt down or depressed before, starting in the least restrictive availability of care is going to be important. So you don't want to send somebody to the hospital or have them sent to maybe like a more intensive community mental health team or something if they're new to this. Either starting them out in some brief therapy, solution-focused brief therapy there at the clinic that you're at, or finding the appropriate referral for them. Health and behavior treatment is also something that we see a lot in this integrated care. Motivational interviewing is used a lot to identify barriers with medication compliance. Again, with the example of diabetes management, if somebody just has no interest at all in checking their blood sugars or taking their insulin, be it because they're feeling depressed or they don't know how, really trying to figure out what we can do to help motivate them to want to take care of themselves. Cognitive behavioral therapy can also be used in these settings for chronic pain or insomnia, helping someone understand how to better manage their physical health concerns will have an effect on their mood, and maybe they can't tie that piece together, so it's important that we want to help educate patients on how these things affect each other. Solution-focused brief therapy is another modality that's really used in the integrated care setting. Again, getting people focused on what has worked in the past and what they can do now, and really just trying to set some good goals and reasonable goals for them too. They might come in and say that they want to have their blood sugar down to normal and they don't want to take any medication. Well, if it's not a reasonable goal, we want to help them come to terms with something that they can work on. So suggestions for counselors. Again, counselors are new to the medical field, so being able to explain the counselor licensure and the differences between counselors and social workers, psychologists, psychiatrists. There's a lot of confusion, even within our discipline of who does what exactly. So wanting to make sure that you can explain your licensure, your scope of practice, and be available to answer questions that a primary care provider or a nurse or someone might have for you if they don't really know the scope of practice that you have. So again, understanding the clear scope of practice and being really clear about things you can and things you cannot do. Some primary care providers might be under the impression that counselors can give medication suggestions, which is really not in our scope of practice whatsoever. So again, we want to be clear and let them know that that's not something that we can help with, but perhaps we can help find them resources if that's what they're looking for. We also want to eliminate insurance and referral barriers by becoming paneled with insurances that are utilized at that clinic. So if your clinic, you're the primary care physician there is using like Blue Cross, Humana, Priority Health, the TRICARE, whatever it might be, being able to see those patients, if you're paneled with those insurances, helps eliminate a barrier as well for both the physician making the referral, but also the patient who's looking for care. We want to make this transition as easy as possible for them so they're willing to engage. Other suggestions for counselors are to seek training in brief interventions. So offering that same-day access is so important. Getting somebody engaged while they're there. They might not come back again and look for mental health services. So if you have them in the room, just getting their buy-in for treatment and how it can help them is really important. Primary care providers can see 15, 20 patients a day. The ability to screen and offer a brief intervention and referral to treatment is so important. We need to be really time sensitive with this, especially if we're using the primary care providers' exam rooms. We want to be respectful of the time that they have and how they have to turn over their rooms pretty quickly as well. Another suggestion is to be able to conceptualize and communicate patient cases and treatment plans. Again, with primary care providers being so busy, they might have a limited time for consultation. So being able to go in and be really clear and concise about what the presenting problem is, what your goals for treatment are, what the patient's goals for treatment are. We want to make sure that we are able to give them a full understanding without taking up an hour of their time. This consultation can take place in that team huddle that I mentioned earlier too. So maybe that huddle is just 15 minutes in the morning where they're running down their patient list with their nurses, and you're able to pop in and say, I noticed this person, I did a chart review on this person, they have a history of depression, I think this might be helpful if I can step in and speak with them while you're meeting with them today. The other term that we see a lot is called curbside consultation, meaning that you're coming up, you've just got a few moments to get your point across and then go on to the next thing. So that might be a term that you hear as you start working in these integrated care fields. Another suggestion that's really helpful is just for counselors to seek training in psychopharmaceuticals. We want to have a really basic understanding of medication and how it helps with this holistic approach, because if a patient comes to us and says, I've been on the sertraline and I don't know why I'm feeling this way, and you don't even know what sertraline is or what it's used for, being able to speak with them and tell them, okay, I can communicate that to your provider. We want to have a really, if nothing else, just a basic understanding of what medications do for people. Something else to consider too is prescribers might use your diagnosis to base their prescriptions from. So primary care providers without a lot of training in mental health might have you go in, do an assessment, maybe you do a PHQ-9 or a GAD-7 or just a quick assessment, and they base their prescriptions off of what you diagnose because they don't know the criteria for everything. Another instance where you might see this is with ADHD in children. So using measurements like the Vanderbilt and being able to score that and tell the primary care provider, these results suggest maybe ADHD or ADD, and then letting that provider decide on their own what they want to prescribe, but giving them the ability to work from a diagnosis that you've given them. So, in summary, the foundation of integrated care is really communication. You want to be communicating with your patients. You want to be communicating with the other providers, with the nurses, with the front desk staff even. Sometimes your clerks are the ones who need to alert you to somebody's needs. So you want to have a really good working relationship with all of these people, and it comes down to just building the relationship. Counselors really need to advocate for their role, and again, as they build these relationships with people, they'll be the other providers will be more likely to refer to them if they have a good understanding of who that person is. They trust their judgment. They know what their scope of practice is. They're more likely to engage in this holistic approach and include the mental health physician or clinician with treatment. And again, it's important to see continued education on brief intervention, integrated care models, and psychotropic medications. These are all things that are really going to become a big part of the counseling field going forward. This is a great opportunity for counselors to join a field that perhaps they weren't really a part of before. We weren't really part of the medical field. So now being able to jump in and carve out our role here, we want to make sure that we're able and ready to fill that void. So being able to go in and offer the very brief interventions, the quick assessments, and being able to work in an integrated care setting, and also again just having a really good understanding of the medications that people are using and what effects those might have.
Hello everyone, and thank you so much for being here today. Today we're going to be discussing Texas Behavioral Health Integration Advisory Committee, so best practices in holistic treatment. Before we get into our discussion, I did just want to go around the room and have each of you introduce yourselves and talk a little bit about what it is that you do on a day-to-day basis.
Sure. I'm Dr. Kendra Saxvik. I am a clinical pharmacy specialist. I specialize in mental health, and I currently work in specialty mental health over at the VA here in Corpus Christi.
And I'm Dr. Pam Green. I'm on faculty here in the College of Nursing and Health Sciences, and I've been here about 3 years. Prior to that, I was in clinical practice in multiple settings for the last 39 years.
I'm Kristyn Heins. I'm an LPC, and I work in primary care mental health integration at the VA outpatient clinic here in Corpus.
Thank you. So to start off, we have 3 different disciplines here, and so one of the first questions that I want to pose to the group is, as far as the opportunities for implementing holistic treatment, this concept of holistic treatment, what does that look like as far as opportunities for growth or benefits from each of your perspectives?
Yeah, it's really a new thing for counselors. We've not really been in the medical setting previously. It's usually psychologists or social workers that you're seeing there. So it's a huge opportunity to grow as a field for us. But we have a lot to learn with that too.
Sure.
We don't learn a lot about how to work on an integrated team in at least my graduate program. So learning how to communicate with medical doctors and understanding what their schedules look like, that they can see 20 people a day. We might only have 2 minutes to consult with them about something. Understanding what a medical chart looks like, not just a counseling record. Figuring out how to read medical charts and track down who gave what diagnosis, and then also kind of understanding how medical diagnoses affect psych diagnoses too. You really have to have a good understanding of that when you're in the integrated field there, because somebody might get sent to you because they're not compliant with their diabetes medication, and you have to understand, okay, well, what does that look like, and what are those meds, how are those administered, and how might somebody be experiencing some barriers from that. So there's a lot of really great opportunity for counselors to expand in this field and carve out their place in this integrated care model.
When I think about the integrated care model, I think about both sides of it, and there are family nurse practitioners serving certainly as primary care providers, and many of them are working in nursing homes, for instance, where they see a lot of the geriatric population who have combined diagnoses with mental health issues. And then there are the psych nurse practitioners as well, and they're in high demand particularly in rural areas, both are in high demand. One of the issues is always the need for a collaborative physician to work within their practices, but there's just a great richness for either of those practitioners. A lot of the FNPs, the family nurse practitioners, do go back and get their certificate as a psych NP because they see so much mental health concern in their primary care practice. But I think that the idea of expanding, including other disciplines, is also a good way to go. So nurses are used to having to collaborate, and so they're good people to have in the mix, hopefully, to facilitate that.
So pharmacy is expanding a lot in the last couple of decades, and some of the new roles is as a part of this healthcare team getting out of the pharmacy and into the clinical setting, and keeping in mind what we can bring to the team. We are the medication experts. We spend a long time learning lots about medications and how they affect the body, but more than that, how medications affect each other and how different things may be beneficial for patients. How do we help them be compliant with their medications? Is there a formulation that they only have to take once a day so they don't forget? Those type of things, we can bring that to the table, and we know that. We were trained for that, but some of the new things that we're really moving towards, I encourage all of my pharmacy students to explore those options. And particularly in mental health, which is my setting, I really focus on how do we interact with patients? How do we interview patients? And a psychiatric interview is a little bit different than a primary care interview.
Sure.
Or is it? Is it really that different? The difference may be that we're not looking as much at objective data on the computer screen, but the objective data that our patient is reporting to us. And so shifting our focus a little bit to focus on how do we get that information from the patient and then integrate it into their whole care. When students come on rotation with me, I tell them at the beginning, even if you don't like psych, by the end of this, you're going to be able to get the information that you need from any patient that you see. And I think that being able to have that skill is a really useful thing to the team, but also to treating the entirety of the patient. Being able to integrate, okay, well, why do you feel this way about these medications? Why don't you want to take these medications? And being able to relay that information back to the team can be a really, really useful place for us as a profession.
Absolutely. And so with that, when we're kind of, what I hear from each of you is that it's kind of not, I wouldn't say a challenge, but it's there are barriers in some way for each profession. So how do you go about kind of overcoming those barriers when you're looking at incorporating something like a holistic treatment approach?
I think advocating for your profession and what you can do, but also your limits, and being open and honest about that with providers. For pharmacists, we can't diagnose. That is one of the big limits of our scopes of practice. However, once that diagnosis is there, either from an LPC, a psychologist, things like that, when we're talking about mental health, or a primary care provider, if we're talking about medical, we can really, really help you find the best treatment option for your patient that's going to work with them. So this is being able to define, this is where we can fit within your goals. And so I think that's one of the best ways to address that barrier. Being open and honest, but also emphasizing where you can fit within an already existing practice, or where you can take an existing practice and improve it.
I think what you said about really being able to articulate what you can do and what the limit or scope is real important for nurse practitioners. For instance, they can assess, diagnose, and treat, prescribe within certain limits, because they do have to have that collaborative physician that they're working with. They can't work 100% autonomously. And now we're adding another layer of the doctorally prepared nurse practitioner, and for people to understand what in the world is a DNP, what does that mean? So being able to explain, kind of having that elevator speech is going to be real important always for clarity, so that individuals know, if I'm a patient, who do I go to, or what is it that they're providing in the team, and whoever is putting the team together to know, who do I need on this team for this patient, who will be the best, what will the mix need to be to meet the needs of this patient. And so understanding the scope of each and the skill set is just hugely important.
Yeah, I think, counselors, we need to play to our strength. We're communicators. So going in and having these conversations with our different providers and even the front desk staff, so they know who you are and what you do. In case somebody walks in and has a complaint, they can get a hold of you right away. Making sure your building administrator knows who you are and what you do. So I think the biggest step, at least from a counseling perspective, to overcoming this new thing where people don't really know what you are or what you do, is communicating and just doing the best that you can and making sure that you're seen, making sure you're present, and people know where to find you and how to get a hold of you.
And it sounds like advocating for your profession as well is really important too. I know you mentioned like new counseling professionals kind of coming in and not necessarily having to ever deal with charts and things of that nature. So also being able to come in and be able to articulate, this is the scope of my practice, and advocating for yourself. However, I'm open to being exposed to these other things and learning these other things. But it sounds like it takes a lot of team support.
Absolutely. You have to learn from your team. Countless times I go to my clinical pharmacist and I say, like, why did this change? Or why is this med suddenly not working? Or, they started this other med and now this one's having these issues. And I don't know anything about medication. I took one psychopharmacology class, and but being able to talk to somebody in person and have them explain it to me in terms I'm going to understand, as well as how to help my patient become or get a little bit better, it's huge. You have to be able to ask for help too.
And I think that's a lesson for every profession, asking for help. And anytime you look at a new setting, a new job, a new anything, looking at what exactly are they doing there? How can I fit in? And how do I understand what they're doing? Because if I don't understand what they're doing, how can I ever understand my role?
And I know in one setting, it became real clear that that we needed our pharmacist there, because I'm saying she because it was a female, had the full picture of all the medications. And it was the point where the psychiatrist wouldn't convene the team if the pharmacist couldn't be there, because it was almost dangerous to adjust medications without full knowledge. And that notion of, I know this medication is good for this, but I don't know how it's going to be affected by their cardiac meds or whatever.
Right. And that has been a role that I have served on a lot of teams, is that, we're trained as pharmacists, we are trained in the holistic treatment. Because we have to be, when we think about drug interactions, drug disease state interactions, those type of things, that's how we're trained. So when we come across a patient, we're not just looking at their psych meds. And it's not that other providers don't look at the whole list, it's just that they're not trained in the same way. They're not trained to critically evaluate that list in the same manner as pharmacists are. And so that can be a really big help to the team.
Well, and I think of some of the diagnostic work that, like you do, you're going to find out stuff that the primary care provider probably didn't find out, like maybe they're dabbling with substances, and maybe they drink a bottle of wine every night and then some, and they're going to go in for surgery and they're going to be NPO for a while, and so people need to know those kinds of things that you know, because they've built that relationship with you. So we all have to just, back to your comment about being a great communicator, share the information, but in a way that is efficient and effective for everybody. We can't sit down and have hour-long conversations over every patient every time we see them.
Yeah, absolutely. And I think whenever any person of any discipline comes into an integrated clinic or some sort of integrated role, they have to be ready to act as a consultant for their specialty.
Certainly.
Dr. Saxvik is my consultant for pharmacy. I'm going to come to a nurse practitioner if I need to know something about nurse practicing. I don't know anything about it. It's not my study. So I need to be able to come to that person, and they have to be able to talk to me, or I need to be able to talk about my field from like a big, bigger picture standpoint. How do counselors do this?
Absolutely.
Not just how do I do this?
Certainly. And so when we're talking about this kind of this collaborative approach, Dr. Green had mentioned that it's not always practical to sit down and have that hour-long discussion with your team members about a patient. So how viable is something like this? What kind of things are available, or what can be done in order to sort of increase the efficiency of something like this from an administrative or systemic standpoint?
I think team huddles in the morning, getting everybody who is on that integrated team together. 15 minutes, we run through the schedule of the day, who's going to be needed where. I used to do that at my old clinic, and we'd look together, and I'd say, like, okay, looks like this person hasn't had their universal screen yet this year. Let me know if something comes up. And I would make sure that I was available during the time that I would expect something.
Some places have shared models of understanding for safety. Team steps is real popular throughout the country. And we know that if I say, I need to cuss, everybody kind of drops what they're doing and gives me, that 3 minutes, because it's a true safety concern in the moment about this patient. Another thing, though, that you have in here in your slides has to do with the use of a portal for sharing information as well.
I think the portal is the way of the future, but it really helps be able to treat the patient as a whole. And from a systemic level and an administrative level, that's probably one of the best implementation things that can be done to really foster this holistic treatment. Because when we're talking about the portal, we're talking about being able to have access to medical records from other providers. And that has been extremely beneficial in places where I've had it in the past. I do work at the VA. Our VA, because of where we are, does not have all of the ancillary services and specialty services available. But I have worked at large VA medical centers that do. And I can tell you it is so beneficial for me as a practitioner to pull up the cardiologist notes, to pull up the surgeon's notes, to pull up the discharge summaries when they got admitted for a blood clot, whatever the case may be, so that I can then turn around and plan my therapeutic plan around that. There are a lot of barriers to being able to implement that. It is expensive. And at our current VA, we have access to some, but not to all. And so that can be a limitation. We have access to the hospital records, but not necessarily to the specialist, the nephrologist that they went and saw after they got out of the hospital for their acute kidney injury. And so we're still kind of trying to piece those things together. And while we're doing that and waiting on records, we are then relying on the patient and their memory. And some patients are great historians and they keep it very well organized. Others aren't, and for a variety of reasons. They don't understand. Or they didn't understand at the time. They were under a lot of stress when they came out of the hospital. They just wanted to get home, so they didn't necessarily integrate everything that they was being told. And so then on the flip side, you're stuck with trying to piece this together from partial information. How do you come up with a treatment plan? Whereas if you had the information, you could see it from the medical provider's perspective and have all of that information ready to go.
And I think as clinics are looking at becoming more integrated, if they can't afford a portal or they don't have access to a portal, just having a shared medical record where your mental health can access it or pharmacy can access it, primary care, just so that all of those notes are there for a number of reasons. One, so I know when I look in, open the chart, I can see like, oh, they just saw their primary care provider. I want to check in on how they're doing with this. Or I might see like, they found out that they have a new cancer diagnosis or something, and being prepared to talk with them about that. Also for communication purposes, if I don't have time to stop by Dr. Saxwick's office and tell her, like, this is what's going on with this person, I can put a note in someone's chart, Dr. Saxwick, please review. Patient reports experiencing these symptoms, wondering if it's a concern with their medication. And tagging her for a signature so it's drawn to her attention, but she can still get to it when she has the moment to do it.
But the reality in our community is that there are a lot of disconnects and fragmentation that we have to be mindful of. So my primary care provider may be able to access information from the hospital, and my primary care provider can access the lab work that I have, but it doesn't really go anyplace else, and I don't have it, and I can't take it to my specialist necessarily unless I ask for a printout. So there are a lot of areas that aren't yet practicing with the technology that is available, and it may be a long time until that happens because of the expense and because of other barriers to that whole process. So again, we may be back into the situation of coaching patients to ask for printouts of their lab work that they can take if they're going to go see a specialist, so it doesn't have to be redone, or if there is someone in private practice seeing a patient for therapy and they find out who the primary care provider is, they may end up needing to call or notify, just so that there's contact information so that there can be sharing. It's labor intensive to do some of that, but we are having to still go old school for some of the communication and to try to make sure that the lines are open to be able to say to the patient that may be seen in the social worker psychologist's office, who is your primary care provider, and get the releases or consent signed so there can be sharing of information when there are critical things that come up. So there's still a lot of basic work in some areas of the community that just have to be done in a pretty cumbersome way, but still are important to get done.
They are really important when we're thinking about treating the patient as a whole. And from an administrative standpoint, supporting the time to be able to do that, having support staff that can be able to, if we do have to get records, making sure that they can get releases of information from the patients and just do the legwork of being able to get that information. So that's one way. If you cannot afford or it's not practical to implement the entire portal, at least having support staff or time built into people's schedules to be able to do that, recognizing that what look like non-productive hours are actually productive. It's just harder to put that into the larger perspective.
Yeah, and when you have a patient who is getting different services from different areas, helping them advocate for holistic care too. Helping them say like, okay, I'm seeing this primary care, but I'm seeing this specialist. I need you guys to talk to each other. I'll sign the release of information. I'll bring the notes to you.
Absolutely, and it sounds like when you're working to kind of in the preliminary stages of incorporating this holistic care, that maybe it is going to take a little more time on all of these different disciplines to really coordinate with one another and collaborate. However, it sounds like when that ball gets rolling, even from a practitioner standpoint, once they start opening up their minds to the idea of collaborating with others, that's kind of the beginning of implementing that.
Absolutely.
And I think at the end of the day, most want what's best, and there is a willingness. There's just a lack of time sometimes, or lack of resources.
Yeah, I would agree. I think all of us were trained to treat the patient as a whole. That the patient is a human being, not a number, and so that means treating all of what they had. And we're on integrated care is cutting edge in getting back to that, thinking about the patient as a whole and how do we fit each of those different pieces together.
Absolutely. I want to thank you guys for your time and thank you for your feedback on this topic.
Thank you.